Great. Well, good afternoon again, everybody. I think that folks are joining, and in view of the fact that we have an hour, it would be good to get going. So as I said, my name is Lucy Gilson. I'm the head of the Health Policy and Systems Division, and we are facilitating this first noon meeting of the UCT School of Public Health this year. And we are absolutely delighted to be joined and to welcome Beth Engelbrecht, who is an adjunct associate professor with the school, and I'm sure many of you know her as the former head of department of the Western Cape Department of Health. And we are really pleased to have an ongoing working collaboration with Beth. And thank you so much, Beth, for joining us today. We very much appreciate it. And Beth's going to be talking to us about learning health systems and supporting learning health systems, which I know is a great passion and around which she has been doing a lot of thinking and work. So as ever in the noon meeting, Beth will present and then we will open it up for discussion and reflections. So Beth, thank you so much, and over to you.
Thank you so much, Lucy. Just check whether the slides is showing.
It's good, Beth. Thank you.
Right. Okay. So thank you very much for the invitation. Clearly, strengthening our health system and focusing on learning and leadership has always been kind of passions of mine. So I'm very excited about doing this presentation. So thanks for the invitation. So the thinking is today is just to briefly talk about learning health systems and then use a case study in kind of its healthcare worker well-being. And from that, identify what were catalytic levers and what does it mean for learning health systems. So yeah, let's go. Firstly, the Alliance for Health Policy and Systems Research in 2021, I think, had this flagship report on learning health systems. And one of the key findings and how they packaged how learning happens in health systems is to talk about the three dimensions. You know, on the left with the blue ones are learning loops, which is very familiar to all of us, single, double, and triple loop. And they each have a place, but ultimately, how do you move more towards triple loop type of learning? Then to the right, the yellow-orange ones are learning across levels, clearly strengthen individuals, strengthen teams, ultimately strengthen the organization, and then across organizations. An organization, it could be a clinic or a hospital or a province. And then the means of learning, whether it's through action or deliberation or information, and all of those contribute to your learning loops and to move across learning levels. They also captured in the flagship report the potential benefits of learning. Now, in the academic life, all of us know the importance of learning, but then for a health system that learns. So the way that I've packaged is to look at the left, your learning loops. And in those learning loops, what is the means of learning in those loops? The single loop is just information, action, and a lot of things that happens actually in that means of learning. And the key change is more informed practices. The potential benefit is improved performance of functions. If you go to your triple loop line, it's information plus deliberation plus action. It's about questioning and changing existing learning frameworks, structures, and processes. And the key change there is increased ability for continuous learning. And then to the very right, the potential benefit is greater self-reliance. And in this report, a very strong point is made about getting health systems to be more self-reliant, to continue to improve itself, to regenerate itself, and it's based on the ability for continuous learning. So the case study I want to share was, you can see it was during COVID time, and the question we had is how could we enhance healthcare worker well-being? In the Western Cape, specifically as the epicenter of the epidemic in the beginning, there was such a lot of pressure on the whole system, and managers were kind of embroiled in a lot of conversations and policy issues and dealing with politics, etc. And healthcare workers just had to face what came their way. And it was very clear that healthcare workers were under tremendous pressure. And the question was, how can we enhance their well-being? So to achieve that healthcare worker wellness, we know it's a global wicked problem. It was not only during COVID. And it does require an asset-based learning approach, a combination of three broad groups of people that needs to come together. Those in practice, those affected, and then researchers and scholars. And in the case study, this asset-based approach was then also followed. So our journey was kind of just reflecting briefly on what we knew when we started, and then came COVID. And then what were some of the stories that emerged? What were some of the actions that we took, and what were the outcomes? I'll touch on those only briefly. So what we knew, and at the bottom you can see there Maria Felime. She wrote a book post-mortem in kind of when she left as an intern in 1999. She just turned her back on the medical career and just walked out. And then she wrote what her experiences were and what gave rise to her to leave the system. Particularly, she focused on the continuous confrontation of disease, of poverty, massive trauma load, and limited resources. The issue of care fatigue, she said it felt like shouldering a boulder every day uphill, and by 4 o'clock you get to the top, just tomorrow morning the boulder is at the bottom again. A lot of moral pressure, consistent, rapid clinical decisions that had to be taken, very often without all the type of specialist inputs in that, inadequate resources, and a limited safety net for the society at large. She also felt that the education system ill-prepared her from being a student to being a healthcare worker. And the health system experience was there was pressure to perform, little understanding of the complexity, and this decision-making was not part of her role and her scope. So interestingly, although that was what Maria Felime documented, this is not unusual. This is happening on a daily basis, then and now. So some of the research, especially around burnout, so burnout is defined as emotional exhaustion, reduced feelings of personal accomplishment, depersonalization. And so the research in high income level countries was that this was one just focusing on kind of burnout, but then in the UK it was only on emotional exhaustion. And it kind of is between 12 and 29% in your high income level countries. Research that was done in the Western Cape showed that in the rural areas, 76% of that the focus was here on general practitioners, your medical officers particularly, that they expressed the symptoms of burnout, and in the metropole, 81%. So clearly a very high prevalence, and this research was done way before COVID came. And then came COVID. To the left of the slide, one can see that COVID added to volatility, a lot of uncertainty, a lot of complexity, and a lot of ambiguity. People might recall that policies were unclear. There were a lot of things coming to the staff. Then it is make sure everybody get the message. Then it is about quarantine and isolation facilities. Then it is kind of a field hospital. Then it is kind of how the PPE is not enough. In all of these and uncertain policies, and the policies kept on changing on a weekly basis. So this added a lot to staff pressure. There was also traumatic exposure, where very often the staff felt this patient is getting better, we've made a turning point, and then just a few hours later, the patient would pass away. and in high numbers, much more than what they've previously been used to in terms of the trauma that they experience and their affection for patients and their wish to do the best. Workload obviously increased tremendously, and very often they had to work different shifts, different places in the facilities, etc. And then home life stressors. When a nurse or a doctor would get home, they had to make sure that they don't transmit any possible COVID viruses. And the kids were uncertain. The kids were at home, they were not at school. There were work experiences that people might lose their job. And then obviously some of the family members or friends or people working with them would pass on. And then particularly moral injury, which is described as a profound psychological distress, which results from actions or the lack thereof. And very often this is where doctors and nurses felt, I could do so much more if I just had even more time or more resources, or I had PPE, or the family could come in, etc. And it violated the moral and ethical code. They felt betrayed. And it's not only the frontline staff, it was also the leaders in the system. So the leaders felt, I'm just going to touch on a few of them, fracture lines in relationships began to show due to the pressure. There was kind of supply chain management was starting to blame this or that, there was a blaming game and finger pointing as a symptom of fatigue that there were many more moving parts than in the past that had to be kept up and still under severe pressure. And there were soul-destroying experiences, as I've just described. And at the bottom, this was a quote from one of the managers, that 90% of my work is about holding people. Staff expect us to be strong. We feel tired, frustrated, guilty. I feel I'm letting my people down. So that context, we thought of what could be a way by which we support the whole system and all healthcare workers. Some action was needed. And clearly taking a step back, we felt it was important that there must be a shared vision of healthy and a functional workforce. If people need to buy into that, then we can take action to get there. We need to create safe spaces to share, to reflect, and to learn from one another, because there were a lot of activities happening across the whole system. And we need to invest in the most important thing that matters. It's about relationships and trust. Now, clearly, the department was doing a lot in this field already. And the fact that there were investments in the past in this space helped a lot. This was just how do we augment work that the department has been doing, and clearly focusing on staff well-being and leadership. What was also important is to create connectedness to the front line across the system, and kind of primary healthcare, rural, primary healthcare, metro, small hospitals, large hospitals, tertiary hospitals. Everybody had similar experiences. And how do we share those learnings to make everybody feel connected to a learning experience of making sure our workforce is as best care as possible? And then establish networks of teams, allowing emergence, but then very particularly was to collaborate with external partners to enhance learning. So the particular external partners we had here was our university colleagues, especially UCT and in UC, where the Institute of Healthcare Improvement was just, they were just incidentally in South Africa at the time, and they just started to participate and play the role and pull some of their knowledge and resources in. We also had experts in occupational health, experts in kind of people management, and ultimately one of the partners, which is actually an internal partner, but very often seen as external, was labor. We brought labor on board, that they also feel the role that they can play for the staff members. So we established this, what we call the hashtag Staff Care Partnership Initiative. And you can see there that it was the Institute for Healthcare Improvement. We worked in 3 provinces, Northwest, Western Cape and Eastern Cape. Most of our learnings have been in Western Cape. That is where we started. The National Department of Health remained connected. The School of Public Health UCT, Nelson Mandela University, Fort Hare, and Northwest University. So all of these actually became a collaborative partnership to say that how can we as a collective strengthen the healthcare system to support and protect healthcare workers. Our theory of change was to focus on the interdependence on leadership and learning and improvement. I kind of just let people know what will be the how part that we will be focusing on. One of the first things we also did was to just check what does the literature say, and can we perhaps get guidance in this regard, so that when actions are developed, they link to kind of some grounding in research. And this was a paper by Tate Schoenfeld in the as a JAMA article in 2020, the American Society Medical Association, where the report here was that they did research. This was in 2020. Research was done to understand what are the sources of anxiety and what could work to address them. So there were 8 sessions with about 70 healthcare workers and support workers to say that what do you care about, what will make a difference, etc. And ultimately, they identified 8 key concerns, and they converted that to 5 requests. Those requests actually, it's very, very simply packaged. Hear me, support me, protect me, prepare me, care for me. Those requests actually, to a large extent, guided a lot of the work in the system, and we could, range of activities that emerged, we could actually link back to these requests. So the external partners, we formed a joint steering committee, and then kind of meeting before kind of the regularly planning sessions, learning sessions, and then also reflect after those sessions. So there was a broad-based collab, a collaborative learning community, and an agile focus group. So the larger group, the collab community, was about, usually the attendance, we had it once every second month, was about 150 to 250 people online. And the agile focus group, about 30 people. And that was people who are willing to try things out, to learn about improvement, to apply certain principles of leadership, and also about learning. And they would then, the focus group would then bring their learnings back into the broader collab community, and then everybody could learn together. One of the principles have been to meet service leaders where they are and meet teams where they were, and work on their context and their realities to support their local efforts. Focus very much on building relationships of trust. Credibility, competency, and reliability became key drivers of the possibility of trust. We ultimately then developed a shared vision and kind of a making sense of what people are asking, what would make a difference. And that was converted into a sense-making framework. And the way that it was approached is that the senior system leaders should leading the process. Although a lot of technical work, working with the smaller teams, work about learning, but ultimately the senior system leadership need to drive the learning journey. So this is just graphically showing. So at the top, you can see the focus groups. They kind of test ideas and they form a rapid improvement cycle. So you can see kind of they were, the action was more frequent and continuous. And then your virtual collab sessions with leaders and healthcare workers. And in those virtual sessions, we would then also break into groups to have discussions on what have you learned, what resonates, is there something that, what do you take away from this? The qualitative feedback has been that people felt more confident about their leadership, about tackling things, and they felt more on top of the system and not only kind of working in the system and just trying to survive. And it ultimately, there was improved emotional health together with all the actions of the department. So these are just a few examples. So I'm not sure whether you'll be able to see the mouse here. So this to the left, these blocks was then the sense-making framework. It was shared and co-created. And you can see there were key actions. Actions were grouped in streams, and ultimately the shared vision of a healthy and functional workforce. And it was leadership, prevent harm to healthcare workers, and then preserve mental and physical health. So what's important is it was nested within an authorizing context, and a culture, an endearing culture where there was caring for each other, and then particularly authorizing. What we found is that often people need to be authorized to connect with somebody else. They need to be authorized to spend their time in a learning session. They need to be authorized to do a lot of other stuff. And then also the external partners to be authorized to fulfill a role in this journey. This particular one with the yes and no bottles was the marble project in Somerset Hospital. Was in the theaters where staff could just take a marble and drop it in the bottle, yes or no, how their day was, and then there were stickies where they could just indicate what didn't go well in that day if they dropped a marble in the no. And it was fascinating to measure the number of yeses and nos over time, and then get a sense of what was the no and what intervention helped to make sure that it doesn't repeat. We also found that huddles, just kind of getting together in the mornings in a huddle where people connect, that connectedness, and very often leaders who are visible in those sessions, the huddles. This is just a Paarl Hospital huddle board. There was an understanding of debriefing. This was a particular learning experience together with labor unions about their role and how there must be mutual trust between the system and those leaders. At the bottom, there's just what matters to night nurse leaders. We had sessions with them. This was George Hospital. They used this framework and then asked the staff to say that what activities in the framework would make a difference to them. And they did really very well. And this was just in Somerset Hospital, where they ultimately, staff asked for just a space to relax. And this was a donation that was gained for Somerset Hospital. So what were the catalytic levers in this learning journey? So I've identified only two for discussion today. The one is partnering and collaboration through collaborative leadership. And then the other one is boundary spanning through boundary spanning leadership. And I will just briefly touch on each of those. So partnering is about relationships. And collaboration is kind of a joint kind of process of decision making to find promising or optimal solutions. So very often people mix partnering collaboration, but actually the partnering is more the relational aspect, and collaboration is kind of the what you do to make the improvement. But obviously the relational aspect is so important. So at the left is just kind of activities within collaborative leadership. Creating synergy is so important. People feel kind of connected to something that all of them believe in. How to innovate, creating psychological safety was so important that people felt it's okay to make mistakes. It's okay to feel emotional for now because of the pressure, and it's okay for me to learn. To appreciate others, to influence culture, power, relationships. Clearly, power is always an issue in the health system, and how does one recognize it and then obviously listen actively? As far as boundary spanning leadership is concerned, clearly there were many boundaries in this journey. There were boundaries between the external partners and the system. Within the system, it was the various districts, it was rural metro, it was primary healthcare, large hospitals, tertiary hospitals, it was the system, and then head office. So there were many boundaries. And clearly, as soon as you tackle a boundary, then very often there's a psychological boundary that step in, and one has to be so aware of this. So this is just the Center for Creative Leadership has identified 5 boundaries of leadership, vertical across levels and authority, horizontal across functions, and that is when people are at a similar level, work horizontally. When there are stakeholders with a stake in the solutions across external groups and interests. Demographic, it could be diverse groups, differences, and I've already mentioned some of those. And then geographic, when there's a big distance. Unfortunately, the virtual world has made just one word about horizontal boundary spanning. That is generally described as the most complex one. I think it's largely because there's a lot of emotions of pride and kind of very often these are my goals, and if I have to support your goals as well, I will not be performing as well as that. So this is quite an important one, and we found that in intersectoral as well, those horizontal boundary spanning. But clearly the skill sets to make boundary spanning work is definitely leadership skills. So there were challenges, power notions, pride and uncertainty. I mentioned this already. So there's a culture of fear due to the massive political pressure in the system. Lack of autonomy, people feel that they are not allowed to do certain things. Mandating an authorization that was needed. And one of the things that we've experienced is that we were endorsed. The work was endorsed and mandated to some extent, but the authorization and especially the resource linked to that was not necessarily there. Reflective practices are not always valued by all. Learning is seen as a soft skill and not an explicit strategy or value, and not prioritized. And busyness, people are so busy, which is definitely a reality. So coming back to the flagship feature they've learned there about, this slide is mechanisms to institutionalize learning. And to the left, you've got the loops, and at the top, you've got the means of learning: information, deliberation, and action. And then the 13 kind of type of activities that they've got to the right are kind of mechanisms and means that the health systems very often use. And to me, this just shows there's not only one way of learning. It must be intentional, and people need to kind of just know where the activities that they are currently performing, where that fits within the broader learning health system framework. So on reflection, if you look at kind of, so clearly in the work that we've been doing, there was largely focusing on deliberation and action. And the action happened within the facilities, and then it was brought back from the focus group into the broader collab community. So those lines that go across deliberation and action kind of were kind of where we would position ourselves. It's a pity that we did not formally. Yet, if one look at number 8 there, for example, innovation labs and pilot schemes. So clearly there's something, there's action there, but the action was not really the learning only. And number 10 was intelligence units for specific topics. So clearly that was also not really what we did. And I found that number 11 could perhaps be the most suitable to position what we've done as part of contributing and supporting a learning health system. So it was participatory learning sites and clearly participating and then bringing it back to the broader community. But one can actually see, whilst this audience is in the academic environment, how many scope, the range of scope there is for academic input into a learning health system. Even M&E systems, data systems for decision support, it's actually, there's such a lot of opportunity to strengthen the health system through a learning health system approach. So some of the insights, this is not comprehensive, just a few of them. Learning needs to be authorized and underpinned by an explicit learning health system strategy. if the organization is not committed to learning, but just doing, and if there's a fault, it is like a massive failure, and the whole system is there, and there's a culture of fear because you made a mistake, but not because you are learning through trying. It must be it must be part of the value system and the culture of the organization. So clearly that strategy needs to encompass all of those things. Important to create flexible, relational, co-created safe spaces for engagement, and definitely psychological safety, and relational. Know people, talk to people in their first name, kind of, and it's flexible, it's kind of 30 people or 28 people, it doesn't matter. And we've co-created it, and it's safe. And a tiered system of, now clearly this was about rapid learning, but a tiered system of learning energizes a stress system. Now, learning in general is a positive experience. And if you've got the tiered system, and I think we were kind of, the time that we invested in this was actually quite limited. It was about a year, May 2020 to about Augustish 2021. So this is quite a limited period that we've implemented this, and it would have been great to have more tiered in this, and perhaps a network of learning spaces across the whole system. And the work in Northwest and Eastern Cape was of a different rate. So what was also important for us was that external partners, like I've mentioned, they bring agility, diversity, and connectedness beyond hierarchy. So it's okay for a UCT professor to talk to a primary healthcare clinic and to talk to a tertiary hospital. But in the general day-to-day work, there's a hierarchy that must be respected, that's communication, and then the power comes in. But external partners bring that agility, and also kind of connect the system to external knowledge. A particular one is to respect the role of health system leaders. They've got a massive job to perform. Speak to what their goals are, what their vision is, and make sure that one supports and respects, align with system goals, be aware of power relations. I think I've mentioned power now so many times. Be aware of power relations, allow for emergence, and build relationships of trust. And then obviously the catalytic levers. It's all in the leadership space. It's about collaborative leadership and boundary spanning leadership. I've just included some reading there. And then, yeah, just a few questions. What resonated in experiences? Yeah, so thank you very much.
Fantastic. Thanks very much, Beth. Really insightful presentation of what was a very rapid experience with a lot of learning at the time. And it's so wonderful to see this sort of reflection on that very intense set of experiences, and very helpful to link it to the Alliance frameworks. But absolutely, you've posed a couple of questions to everybody else in the room, and we've got time for discussion and wider sharing of experiences. So I open it up to points of clarification, points of addition, questions or comments. And please do just put your hand up so I can see who wants to add in, and then we can learn together around the experience that Beth presented. Farzaneh has just requested the slide, Beth, with the readings, if it's possible just to show that. Thank you. So those are the questions, and please, I welcome inputs. So Beth, I'm going to go first while people are thinking and listening. So one of the points you made and indicated was that things like learning and reflective practice are seen as soft, that strange phrase, and often not valued or prioritized, and then get crowded out is my contribution, in the face of the need to worry about service delivery, meeting health challenges and so on. And I'm wondering what thoughts you might have about how we can together work to prioritize those areas of skills and needs so that they are valued and they aren't crowded out. I think I see I see a point, also a hand from Virginia. So I wonder, Virginia, if you'd like to chip in too, and then I'll take Sue Cleary, and we'll pause at those 3 comments, Beth, if that's okay, and come back to you. So Virginia first, and then Sue Cleary.
Thanks so much, Beth, for a fantastic presentation. I just want to give some experience of how spanning boundaries vertically and horizontally can be hugely energizing and a fantastic learning experience. You know, we had that also in, I missed the beginning, so I'm sorry about that. We span boundaries for the COVID response in our department in the Western Cape. And one of the initiatives that we did do, which of course we have a bit doubts about its effectiveness in the longer term, was getting people involved in case and contact tracing, which we spanned boundaries. We got medical students involved who remarked, we've done some research with them, who remarked that it was the first time they had an experience where they were an equal member of the team. You know, our training is very hierarchical. They see themselves as being at the bottom of the rung in the chain in the hospitals, with registrars there and then consultants and swanning around, going on grand ward rounds, etc. So the learning model is quite vertical and very hierarchical, and they explicitly remarked on that it was the first time, and oh my word, how amazing was this. They discovered a lot about COVID. Nobody knew anything about it, so they were at the same level as everybody else learning. So, and that was very energizing for them. And then also, you know, we did span boundaries in the department. We got volunteers from corporate services to join those teams, and some of them were absolutely extraordinary, and stayed involved in the work for over a year each. And I think it's built, you know, it's enabled the department to become a much more friendly space. You know, for people to request to be able to work from home. Nobody ever would have ever dreamt of doing something like that in the past, and that is certainly more of the culture now. So thanks so much for actually systematizing it and putting into some kind of theoretical framework. Yeah.
Thanks, Virginia. Sue, over to you.
Hi, colleagues. Thank you so much, Beth. That was absolutely stunning as usual, and it's so wonderful to have your rich insights and ongoing engagement with the school. So much appreciated. And so mine is just a comment on the issue of a system being too busy and not having time to learn or co-create. And my view is that much of the enablement for learning can be within the existing routine spaces, the existing meetings, the existing practices. So it doesn't have to take more time. It can be a way of using that existing time, but just in a way that enables co-creation, that enables collaboration, that enables people to be together in a particular way. So speaking as a health economist, it is extremely cost effective. No debate. Thank you.
Thanks, Sue. Good to get the economist's stamp of approval. Beth, some responses or further reflections? And colleagues, please do put your hand up so I can come to you if you're interested in joining the conversation. Over to you, Beth.
Thank you very much. And there's been such a lot of kind of richness when people started to reflect on their role, what they did, how they did things differently during the COVID period. It's actually unfortunate that we are kind of letting that go, those relationships, those collaboration, the way students are being trained, and I think it's happening on our watch. We are allowing it. We had the opportunity of living through this pandemic, and there will be another one. And kind of, and this is kind of what's happening. So just on the particular points that were raised, the point I made about an organization to have an explicit strategy and the priority as a learning health system, I think that's quite an important aspect, because in that strategy you can't talk about a learning health system without an enabling culture, without a culture of learning, without allowing learning to happen, allowing mistakes to happen, and also defining where will learning take place. And on the point that Sue made about kind of extremely cost effective, personally I experienced, clearly people are really busy. But when you come together in a meeting and you allow for a few minutes of just reflection of where are we as a department, what is happening, etc., the meeting goes much faster, better decisions are being taken, and you can see people are more engaged. And if something has happened, for example, we had kind of, and I know that Keith has been doing that consistently also now after COVID, is kind of, and during COVID, to reflect on what's happening. Where are we? What does the data say? Should we go a different course? Etc. So reflective practice is ingrained in a learning health system, but it must be stated explicitly. It's not something that come naturally for many people, especially your alpha leaders. If there's something like that, they want to get performance, progress, data, focusing on the what and not the how. And it is definitely a growth point to allow emergence, to allow learning to happen. And when leaders are visible in the front line and they are not there to kind of find what's wrong, but they are there to say, what have you learned? How do you, it changed the focus of making mistakes to what am I learning? It's like allowing growth to drive change. And yeah, so I think that's a very important point. The system being too busy consciously one needs to take care of this. Now clearly there's a myriad of things that must be done on a daily basis, but always try and have spaces where you discuss and talk. How can we proactively make sure that we are ahead of the wave, so that things are in place about connections, or you've listened to the staff, you've identified preemptively certain things that might come your way, so you proactively engage. So you're always ahead of the curve, and that allow you to have space to think and to engage. Otherwise, you're in crisis mode all the time. So being too busy is a symptom of crisis leadership, and clearly that is something very often political pressure drives that, or other aspects. Then Lucy, you asked about kind of how to prioritize that and kind of the skills for learning and reflective practice. Perhaps we should get into the training programs of students, and I'm sure what Sue has raised about the medical students and their involvement, to be just an ordinary healthcare worker doing a basic thing. And then be reflective about that. One can actually have it ingrained into the culture of how people care for patients and how they grow as leaders. Yeah, so I think it's an exciting challenge for all of us.
Thanks very much, Beth. Jill, I note your hand, but I also first just want to note Nandi's comment in the chat about the importance of personal relationships. But also there are a risk if connecting structures are not formalized for future responses. So Jill, over to you.
Thanks. Hi, Beth. Thank you. That was fantastic. And so many of us are thinking about related things, and it's just useful to sort of get our brains going again in the new year. So as you know, we've got that broader project of work on health system responsiveness, which we're also working on in the Western Cape with the Western Cape partners. And I suppose I have been increasingly sort of wondering where the work on responsiveness connects to the work on learning systems. And even if you think about in the Western Cape Department of Health, there's the posters which talk about the importance of a responsive health system. And I was just wondering, in this case experience, whether I suppose I was just sitting listening and thinking, does it come down to where the feedback comes from? So is learning seen mainly as something where people learn lessons and the feedback is from other staff members, and as you mentioned, academics bringing experiences in via journal papers and things like that? Or is the thinking around learning systems also connected to this idea about feedback loops from community, all of those more difficult things to do together, expectations and ideas from the broader health system, I suppose. So sorry, it's a bit of a ramble, but I was just wondering how those ideas connect to each other in your experience.
Thank you very much. Thanks, Lucy. I'm going to respond. That is
Mm.
a very exciting question that Jill has asked. And I don't think it's an either or. Clearly, the one slide that I ultimately took out was about recognizing the complexity of the health system and the public health and public management in general has got toxicity and complexities and the need for collaboration much more than other systems. And you need to have comfort to be able to engage with different groups. Many of our leaders feel uncomfortable with engaging with community groups because they can be very voice their angry, and they demand certain things, etc. And what is the skill set that one built in our healthcare leaders to be able to engage in a way that ultimately it is accommodating, it is about learning, it's about adapting all the time. So I fully agree with you that responsiveness is an aspect, from my perspective, is an aspect of transformation. To be able to be responsive, you need to be able to adapt. You need to be able to absorb. You need to be able to transform yourself. And you need to be able to say that, what should I do differently to be able to do that? And obviously, all of those require some learning to happen. And I agree with you that learning, the eyes of those that are at the receiving end of the care are the voices that you one need to have in the system, because they can see they are living in the space. They are the recipients of a care system, and their feedback actually critical for improvement, for responsiveness. Because how do you define responsiveness in series and responsiveness in another place? You need to speak to those people who are at the receiving end. I hope this helps.
Thanks, Beth. I mean, just also to pick up on that point, and it seems to me that if we understand systems as sets of relationships, and that systems are not exclusively about the management of healthcare services, but are overlapping sets of systems that speak to the wider public, to geographic communities, to people in communities, to patients and to users, then in that which you've been talking about, it's about sort of trying to build those relationships, the confidence to develop those relationships, to maintain those relationships. And that has the potential for then strengthening other relationships. That's my thought. But I also want to pick up on a point that Leslie's made, maybe slightly paraphrasing you, Leslie, forgive me, but in COVID, lots that was different was possible. How do we sustain new ways of thinking, including something like the learning network that you've been talking about beyond the COVID era? How do we avoid just going back to the silos, the fragmentation, the lack of learning? And I wonder what your thoughts are about that, Beth.
I think it's a difficult one. Yet we need to find a way to respond to that question. Critically, we were united by a common fear and a common threat. And the common threat was COVID. So it was not too difficult to unite people around a common threat. Now that we the threat is not as threatening as it has been, but there are other aspects that still unite us with other partners. Some of the examples that were mentioned. And in a smaller setting, those relationships have been built, and people wouldn't have participated if they do not feel committed to a bigger picture, a greater cause. And how do we package that greater cause that people can see themselves fulfilling a role in that, and there is appreciation for the role. It is kind of recognized that they've got a role. Yeah, so I think again it comes back to kind of thinking about the system, thinking about kind of the broader, you know, I don't want to call it a threat, but a challenge that we have is to improve health. The challenge that we have is to make sure that everybody has access and that the most vulnerable are getting it as best as they can. And what are the type of partners that would help us on that journey? It might be that the partners are largely focusing on strengthening the hand of leaders in their job. So I think we have to take a step back and look at what are the current spaces that one could use, or the partners that we built relationships with, to find a way by which one can connect them to some of the areas that will improve society and improve well-being. And they must see that there's something in it for them. So I think it's quite a challenge, but I think we are allowing to go back and let go of those experiences of the.
I wonder, Beth, whether you would feel, and I raise this point because of one of the last slides and the looking at different mechanisms of learning and within the health system, which of course overlaps with the educational system, which is where many of us on this call are located. And I wonder if one response to the how do we not lose the energy and the innovations of COVID is that we in the educational system have also to continue to innovate, to engage, rather than sort of seeing it as outside our area of responsibility. Is that appropriate? I'll
definitely support that position, Lucy. And I think the people in the academic arena has got a great responsibility, because in the general public's eye, academia are seen as independent, really politically affiliated. So their voice has got a much more powerful voice than others. And clearly to be able to harness and I think that the ability to connect across silos, to connect across organizations, is definitely what the academia can do, and to bring that back into the system to energize it. So I fully agree with that.
Thanks, Beth. Panyo, welcome. Please, what's your point?
Oh, thank you so much. My question is, to what extent are these lessons also valid for the private sector? And I mean, how many of the participants, or how many of these observations also occurred in that private, exclusively private sector? So those GPs and maybe the bigger private health facilities where you don't have many uninsured patients and people who are from the community.
So it's a good question. Just to share an experience, we engaged with a private hospital in the Eastern Cape because they had quite a large number of their staff that were tested COVID positive. And we, again, from a healthcare worker support perspective, we engaged to say that, can we be of assistance? It's pro bono, you don't have to pay money, but we will work with you. You could also do a little marble project that staff at least feel that they are supported, or any other project. We had some brilliant inputs from Brazil, for example. And it was very interesting that they initially was so positive, etc. And then the day later said, no, but their hospital group, he checked with the hospital group, and the hospital group said, no, we do our own thing. We don't want others to come in. So I think there's definitely a need for learning spaces, learning experiences. The dynamics in the private facilities are different. General practitioners definitely play a different role. So I think bringing people into a kind of a system of learning, and accept that the system, you know, the health system is about learning all the time, continuously, to be able to regenerate itself. You know, that would be some of the critical things. In this process of #StaffCare, we did have private colleagues who joined, and we invited one of them to give an input. And kind of, again, I could see that kind of very, very cautious approach to not to divulge too much, to talk about what they do, talk about their data, talk about strategies, etc. So I think there's a bit of, I wouldn't call it lack of trust. I think it's just kind of the authorization to be able to engage freely. I think that is definitely an aspect that would be something that we need to.
Thank you so much, Beth. I don't see any more hands. I'll just give a couple of minutes in case a couple of pauses in case anybody would like to raise any other points. Great. Well, I think it's been a really stimulating discussion, Beth. Very much appreciate the reflection, and perhaps a good stimulus for the School of Public Health as it looks to the future and its role in relation to the promotion, protection of public health at large, and of equity in relation to public health. What's our learning role? And really, I think your presentation is stimulating us to say, what are our many learning roles? And education is one of those, but not the only one. So greatly appreciated input. Thank you to all the colleagues who are present, and we look forward to seeing you in future noon meetings. Good luck with load shedding, everybody, and thank you.
Thank you. Thank you. Goodbye.